Good evening, everybody, my professors and colleagues. I am very happy to be with you all today in the second webinar on the scientific activity titled Best Practices in the Management of Men Living with HIV. I am Ahmed Kurdi, lecturer of endemic medicine at Cairo University, and I'm the coordinator of the Qasr Al-Aini HIV AIDS and viral hepatitis fighting group. We have the first activity or the first webinar about the best practices in the management of women living with HIV last Saturday, the 18th of July, with a group of the eminent professors who are working in the field of HIV/AIDS. And today we are blessed to be with you all to present the second wave of the same activity. And I need to share some slides with you all. It will be like a recap about the last meeting. Also, we need to know why we are talking about the best practices in the management of women living with HIV at this time. So let's start by talking about why women. When we say why women, I can go back in my memories to our session that was in collaboration with the United Conference of the Hepatogastroenterology and Infectious Diseases at 2019. During this conference, we had a very interesting lecture by Professor Paolo Angeli, and by the end of his talk, he looked at me. I was honored to be one of the organizing committee, and told me that he was very surprised to see that all the attendees in our conference are equally males and females, and the women were very well represented. So we are talking about representation of the women and equality. And regarding the women living with HIV, we can say that women accounts for about more than half the number of the people who are living with HIV worldwide. And unfortunately, the young women who are aged from 10 to 24 years old are twice more likely to acquire HIV than young men in the same age. And this disproportionate affection of the females and the adolescent girls related to the vulnerabilities related to the unequal cultural, social, and economic status. And let's say that HIV per se does not discriminate against its target. The problem is that it exaggerates the inequalities that we have in the society. And that's why in our meeting today, we have a very interesting talk by the UNAIDS representatives, Mrs. Samah Said and Dr. Wala Ismail, about the attitudes toward the health and childbearing among women living with HIV. When I come back to my question, why women, I can tell you that it is the only gateway to reduce the mother-to-child transmission of HIV. And here I can borrow this slide from the presentation made by Dr. Hiba Said, the NAB manager, National AIDS Program Manager in Egypt. In the last meeting, she told us that since 2014, that 100% of the infants who are born to women living with HIV who were reached and received the package of the prevention of mother-to-child transmission, they had a negative babies. So it is possible, and it deserves to make a lot of meetings and exert a lot of efforts to keep this young generation free of HIV and HIV negative. When I come back to why women, we can see that globally the adult women are more likely to be accessing the antiretroviral therapy than men. And in 2017 records, they told that 65% of the women living with HIV had access to treatment, compared to 53% of the men living with HIV. But when we come to the MENA region, where Egypt is located in the Middle East and North Africa region, we can say that the number of men living with HIV are far greater than the number of women, but the new infections are increasing also among women. And we have to highlight that the women here are particularly at risk for the HIV transmission as a result of the sex within marriage, not as a risky sexual behaviors. And for example, in Iran, they are reported that 3/4 of the women living with HIV, they acquired their virus from their husbands or who get infection from injecting drugs. And when we come, I can come back to the presentation made by Dr. Hiba, the NAB manager. She told us about the challenges that women living with HIV are facing in Egypt. She told us that they are facing a lot of stigma. So they have a limitation for testing, which is the gateway for accessing the service related to testing and the treatment. Also, they are lacking the knowledge about HIV/AIDS. Also, they have some gender issues related to the sexual and reproductive health services. And it's important to highlight that they are feeling false safety because the women themselves does not practice risky behaviors, and they, by the end, getting the infection from their husbands who are having risky behaviors, especially the IV drug use. And that's why we have to make stress on the importance of involving the men in the act or on the response to provide better health care services for women. Back to the presentation of Dr. Heba, she was not talking only about the challenges. She also told us about opportunities. According to her, she is telling that Egypt now having a national screening program for the pregnant women. First phase was started before the COVID-19 pandemic in 4 governorates, and they are aiming to do screening for a target of 2.5 million pregnant women per year, which is very good and eminent program. We wish them the best for it. When we come back to the MENA region, we can see that in the MENA region, the women living with HIV have major gap in the HIV services, and they don't have a very good access for testing and treatment. Also, the gender inequality, the gender-based violence, and the lack of comprehensive sexual and reproductive health services, including the low HIV testing and low access to treatment, are making a great obstacle. And in Egypt specifically, we had a very interesting talk by Dr. Dua Arabi in the last meeting. She's an independent HIV consultant, and she had a real life experience and field experience with the women living with HIV. She told us that some of the women living with HIV were diagnosed after the alignment and HIV diagnosis in their children and their husbands, and several of them reported to have increased the frequency of discharge and itching following the diagnosis. However, they didn't seek the treatment for stigma and discrimination. So it is always about stigma and discrimination. Also, she told us that this fear made a lot of these females are does not have the desire for getting pregnant, or the fear of transmitting the infection or the virus to their children because they don't know how to prevent their children. Also, they told us that the pregnant female who need to deliver the baby, due to discrimination and stigma, they found a very hard times at their most vulnerable moments in their lives. So it is also more complicated when it comes to the contraception issue. I can borrow this slide from her presentation directly. She was saying that we have a limited choices for contraception for the women living with HIV, and also always the healthcare providers telling the people or the women living with HIV that using the condom is the best method for their dual protection. But as you know, the usage of the condom usually is related to the husband who does not need to use or refuse to use it. So we have today a very interesting talk by Dr. Yvonne Cleese about the updates in the opportunities in the contraception in the women living with HIV. Dr. Yvonne is the Iuds WAVE Vice Chair, and she is the honorary clinical reader and consultant in HIV and sexual health. Also, she is the chair of the British HIV Association HIV and pregnancy guidelines. So we are waiting for Dr. Yvonne for this interesting presentation, and also I need to thank her and thank the European Medical Society for endorsing this meeting and the continuous support. When we come back to the last slide in this part related why women, we can say that the reproductive health needs for the women living with HIV are similar with the healthy women. It is all about stigma, about discrimination, about the barriers that they are facing in our communities, especially in Egypt and especially in the area of the Middle East and North Africa. When we come to unique about living with HIV, I can start this section by talking about the U equals U fact. Now it is fact. People who are living with HIV and have undetectable viral load cannot transmit the HIV sexually. This has a very good evidence from partner 1 and partner 2 studies, and also some real life evidence. But the problem here, according to Professor Ibrahim Kabash, is professor of public health in Tanta University. He had a very interesting talk in the last webinar, and he told us that the problem mainly is related to keeping the people undetectable, because this is related to the awareness level and the stigma, and it's also related to the compliance to antiretroviral therapy. Fortunately, he highlighted that even the healthcare providers have a hand in the more awareness and stigma, and also have a hand in the compliance with antiretroviral therapy. He follow up dealing with the side effects, and according to him, we have inadequate compliance with antiretroviral therapy in some patients, and also we have lack of studies that focus on the level of compliance and the barriers to antiretroviral therapy, and that's why we are always in the group of Asraini who are fighting HIV and viral hepatitis. We are calling for doing a lot of research work and to inspire the people who are in charge for the HIV response in our region to be able to make more successful this trial. When we come back to Professor Ibrahim Kabash presentation, he told us a very important note about the importance of having maternal and premarital HIV screening and its leading role in the prevention of HIV transmission. The second point in the section about what is unique about living with HIV is the proper selection of the ERVs. And we had a very good lecture by Dr. Mustafa Bishawi, IDK organizer in the last meeting, and he told us, according to the HHS guidelines, that persons with childbearing potential who are trying to conceive are better to initiate regimens that containing raltegravir, atazanavir, darunavir plus dropivaridine fumarate, emtricitabine, or lamivudine, and that the dolutegravir is an alternative rather than a preferred option for those people. Also, this is slide from his presentation. He was telling us that according to the available evidence, the dolutegravir exposure around the time of conception is associated by small, but it was significant increase in the risk of neural tube defect in the Botswana trial. It was 0.3%. Also, it's based on the evidence available now. The AIDS info recommendations told that dolutegravir is a preferred drug for the pregnant women, respective to the trimester, and this was also certified by the WHO guidelines. But it is an alternative drug for the women who are trying to conceive. But this was the evidence that is available. But interestingly, in the virtual conference, there was a new update from the TISPAMO study in April 2020. They are telling us that the old figures that was telling that dolutegravir was associated by 0.3 compared to 0.1 instance, prevalence of the neural tube defect. Now in the new update, they are telling that it is now 0.19% compared to 0.11%. So it is not significant anymore, and it is safe to use the dolutegravir even during the time of conception or preconception region. So we have today a very interesting lecture by Kwame Jallo about the updates of the HIV related women health issues from her experience in the CROI 2020 and AIDS 2020. I'm waiting for Kwame to tell us about this very interesting updates. Kwame is the Itpc, the International Treatment Preparedness Coalition Director of Global Programs and Advocacy. Interestingly, I can see a very interesting fact in the few slides that I still have, that in another update from AIDS 2020, that the treatment-related obesity can increase the adverse pregnancy outcomes and infant outcomes, especially with the TAF and dolutegravir-based regimens. And these results were a modeling study that came or based on the instant obesity from the advanced trial, that where 14% of the women have developed obesity at 96 weeks. This very interesting results of this study can move us to the usual shifts of HIV from being an acute and debilitating disease to a chronic disease with a lot of comorbidities related to the HIV itself and the antiretroviral therapy related side effects and comorbidities. And that's why we have a very interesting lecture by Dr. Mohammad Chakron here. He is an eminent HIV/AIDS consultant in Abbasiyah Fever Hospital, and he is member of the South African Society of HIV Clinicians. He will talk to us about the bone health and other comorbidities that are facing the women living with HIV and their opportunity for getting well with it. The last slide here is about the WHO fact sheet about the sexually transmitted infections that is telling about the human papillomavirus and HIV. We have around 291 million women with human papillomavirus infection, and we have about 36.5 million people who are living with HIV, and about more than 1 million people acquire the sexually transmitted infection every day. But from all the sexually transmitted infections, we have only 2 infections who are easily preventable through the vaccines. The hepatitis B vaccine have already, the viral hepatitis vaccine for hepatitis B have prevented an estimated number of 1.3 million deaths from the chronic liver disease and cancer. And the human papillomavirus vaccine could prevent the deaths of more than 4 million women over the next decade in the low and middle income countries, where most of the cases with cervical cancer occurs if 70% vaccination coverage have been achieved. So we have a very interesting lecture by Professor Mohammad Chakron about the human papillomavirus-related skin lesions and cervical cancer screening in the women living with HIV. Professor Chakron is the head of the Department of Infectious Diseases at Fatuma Bougeba Teaching Hospital in Tunisia, and he's also a university professor that has used to join us in Egypt as a very brilliant expert, and we are very happy to have him today. In the last slide, I want to ask to thank our colleagues and MSD for sponsoring this meeting, and I can introduce to you now Dr. Michael Sadiq. He is the representative of MSD. They have a few slides to talk about the portfolio of the company and their efforts to support people living with HIV, after which we will start the talk by Dr. Yvonne Tariq. So Dr. Michael, you can start.
Okay, thank you, Dr. Ahmed, and thank you everybody for attending this meeting. On behalf of MSD, the sponsor for this meeting, I would like to welcome you all and wish you a fruitful and insightful meeting. Just before starting a meeting, just to give a quick hint about MSD and its role in protecting human health and also animal health as well. So our legacy in MSD of invention started more than a century ago, and it continues until today. So in these more than almost 130 years, MSD was able to come up with so many innovations that changed the way the HCPs deal with their physicians, starting from 1891 with the establishment of Merck & Co. And then so many drugs that we discovered, like the first diphtheria antitoxin, the first company to synthesize vitamin B1, and the penicillin G, and also the streptomycin and the dexamethasone. These are all inventions made by MSD, which was a game changer in the management of patients with different conditions. So our vision is to make a difference in the lives of people globally through innovative medicines, vaccines, and animal health products. And our mission is to discover, develop, and provide innovative products and services that save and improve lives around the world. So I'm just going to quickly highlight some of the initiatives that we make that are really changing the lives of millions of people around the world. Our main research areas are diabetes, infectious diseases, oncology, vaccines, animal health products, and also cardiovascular, women's health, and the sleep disorders. So talking about vaccines, we're proud to say that MSD is the only company that has an FDA and European approved vaccine for Ebola virus. And it was one of the first companies or the front runners in the fight against Ebola. And still we're continuing to develop more and more vaccines. And just to highlight our amazing work in vaccines, during the last 25 years, there has been only 7 vaccines that were approved worldwide. 4 of those vaccines were developed by Merck. So that speaks volumes about our expertise in the field of vaccines development. One of the main initiatives that we're developing for our patients is the MSD for Mothers. MSD for Mothers is a $500 million initiative that is aiming at reducing maternal mortality worldwide. And so far, up to now, we collaborated in 48 countries with more than 160 partners, and more than 10 million women have been reached and protected through this program. Another important program is the Mectizan donation program. Since more than 30 years ago, MSD committed to donate Mectizan for as long as possible and as much as needed to totally eliminate river blindness in Africa and other parts of the South America. So this is also more than 300 million people that we reached annually with this initiative. Another important part is our commitment to eliminate rabies among the dogs, and we donated more than 3 million doses of our vaccine to various projects around the world, reducing the number of domestic and wild dog infected with rabies. And also about our employees, and since we're talking today about women and their equal representation in every part of our lives, we say that proudly, we're saying that 32% of the executive roles in MSD are held by women, and 33% of the members of the board are women, and also more than 114,000 employee volunteer hours in 2018. So this speaks also about our care for all the people groups around the world, not just outside, but also inside MSD. Talking in the last slide about extensive research of MSD in the field of HIV. So starting from 1996, we've been able to discover so many products like the Indinavir, the first protease inhibitor, the efavirenz, the famous NNRTI. In 2000, we announced a collaboration with Bill Gates Foundation to fight HIV in Africa. In 2007, we discovered the first integrase inhibitor, which is raltegravir, and we were able to develop the once-daily raltegravir since 2017. In 2018, we were able to discover and approve doravirine, which is a novel NNRTI and approved in the US and other countries worldwide. In 2019, we began phase 3 trials for islatravir, which is a new class called nucleoside reverse transcriptase translocation inhibitor, which can be used either as a treatment or a PrEP, and even it can be prepared as a subcutaneous implant for twice yearly PrEP for patients, which is a major breakthrough for those patients at high risk of being affected with HIV. And we announced in 2020 this year that we supported the screening of 1 million African women for cervical cancer in Africa. And this was done in collaboration with the UNAIDS and the PEPFAR, which is the US President Emergency Program for AIDS relief. So we have a long history, we have a strong legacy, and we're also looking forward to a bright future in which we will support our patients and also our physicians. Thank you so much. And now I'd like to pass the presentation to Dr. Yvonne Gillis to talk to us about the conception in women living with HIV.
So, thank you very much to UKID for inviting me to speak this evening on behalf of Women Against Viruses in Europe, a subcommittee of EACTS, the European Clinical Society. And thank you, Dr. Ahmed, for that wonderful introduction. So what I'm going to try and take you through today is just an update on contraception, but also going back to basics for women living with HIV and situations that may arise. So I'm going to start a little bit about HIV epidemiology, although I think you've been well introduced to this already by previous speakers, and also mentioning HIV and desires for family. And I know there's a specific talk on this, but it's important in this context also. I will talk about the contraception options that are available to women living with HIV and considerations when discussing this with a woman. And also think about the discussion that might be necessary for women declining contraception. HIV, I know, has its own talk as well, but again, I just wanted to touch on it briefly in this context also, and models of care for women living with HIV, which may support all of the above. So we know worldwide that there are 38 million people living with HIV, the majority of whom are women, many of whom are within childbearing years, particularly the 15 to 24 year age group. And we know that ART coverage, as Dr. Ahmed previously talked about, is more common in particularly looking at the WHO per region, but there is still lots of work to do. And we know from recent WHO figures that actually Egypt has seen a huge number, just particularly one country, a huge number, percentage increase in the number of people availing of ART. And this is really tremendous to see. So thinking about somebody presenting to you for the first time with HIV, I think all people, men and women, should have a discussion with their healthcare provider about their desires for family. So we always talk about the natural history of HIV and the prognosis in the context of 2020. We take a full medical history, but it's really important at the first opportunity to talk about whether or not somebody wants to have children, and if not, why not? Could this be, this is a change since the diagnosis of HIV has been made known to them? And I know there are specific sessions on mother-to-child transmission, and there's been discussions about undetectable equals untransmittable, but all of this is part of how I would broach a conversation of contraception with somebody. So think about the options available for women. So there is the male condom, which is very good at reducing HIV transmission, particularly in the context of 0 different partners, but it requires really consistent use. And even with consistent or perfect use, there's only about there will be 3% pregnancy rate. But the reality is it's higher than this in real life, as often there are condom breaks or condoms don't get used as often as they should be. They will, however, give some protection against other STIs. The cons are, again, as I talked about, rarely consistent use, and it's not a female-controlled form of contraception. So this can be difficult if a woman is subject to potentially domestic violence or to pressure within a relationship. The female condom has less vaginal exposure to sperm. It's a good contraceptive, and there's less breakage than where condoms are used. And it is effective at preventing HIV transmission, again, in 0 different couples, and preventing STI acquisition. And the woman controls this. However, it's expensive. It's not easily available. It's certainly not something that we routinely give out in our clinic or that women request. And it's certainly not discreet. Then thinking about the diaphragm, which can be used with a gel or a cream, it's very effective as a form of contraception. It's female controlled and it's completely reversible each time it is removed. The cons is that it may put a woman at risk of sexually transmitted infection, and the spermicidal gel or cream that is used in conjunction with this, and is very important to use in conjunction with this, can increase a woman's risk of transmitting HIV or acquiring an STI. And again, it's not discreet. Woman must put it in before sex, so it's not something that potentially she can always be in control of. We then move on to progesterone intramuscularly, and this is something that is used by significant numbers of women worldwide. And we have Depo-Provera, which was the original IM progesterone, being used every 13 weeks. Then we have Cyanopress, which is new and self-administered by the woman herself, again administered every 13 weeks. And then Noresterat, which is administered every 8 weeks. It's very effective. And for women who have difficulty swallowing pills, this can be brilliant because it's once every 3 months, and then they don't have to think about it again. And particularly if women aren't good at taking pills or their adherence is an issue, this may be a very effective form of contraception. There is no interaction with the common drugs that we use for treatment of HIV that significantly enhance cytochrome P450, so that's the NNRTIs or PIs. And it is female controlled, and it's very useful for women who are unable to take estrogen. The cons of using progesterone is that it's really labor intensive. So the woman has to attend a clinic to have the injection, and the injection has to be given by a health caregiver if she's not happy to use Cyanopress or if that's not available. Women don't always like injections. Some people are very needle phobic, and we know sometimes we struggle to get routine blood tests from patients because they don't like needles. It is reversible, but fertility can take up to 12 months to return to normal on stopping, which can be a real problem. And then I know you're having a talk on bone mineral density specifically, and this is one issue that can be a real problem, particularly if there are other comorbidities or ARVs that may be increasing a woman's bone mineral density reduction risk. There have been concerns about increased transmission in some countries with regards to progesterone, but this hasn't been the same in all countries, and as yet an exact mode as to why this might be happening hasn't really been clearly elucidated. Moving on then to intrauterine device or copper IUD, it's very effective as contraception. There doesn't seem to be any interaction with HIV itself, but if a woman isn't on treatment and her viral load is above 50, there is potentially a risk of increasing HIV transmission where there are serodifferent couples. There's always a concern with IUDs that there may be an increased risk of pelvic inflammatory disease. However, this risk in reality is actually quite low. The benefit of using an IUD is that there are no drug-drug interactions to worry about. It can be very useful if you want to avoid STIs in combination with condoms, because then you get even more protection. It's also very useful as emergency contraception. It's used quite commonly in the UK for up to 5 days after unprotected sex and can remain in situ for 5 to 10 years, depending on the age of the woman at that point. And a woman can choose this and be in control of this mode of contraception. A problem with the IUD is that the worries about infection may limit the number of women accessing it, and having a sexual health screen is very important to do. It can cause heavy bleeding and painful bleeding, which many women can find very difficult to tolerate. There is also an increased risk of ectopic pregnancy should there be that failure as a contraceptive device. But fertility returns completely to normal on removal, and it can be used to see women through menopause if they're on fertility. It's used for 2 years after their last period, and for women over 50, it's used for 1 year. It can remain in situ for 1 year after their last period. Moving on then to emergency contraception. Hormonal contraception, if an IUD is not possible, can be used, but double dose must be used in the context of enzyme-inducing drugs, commonly the NNRTIs and PIs, and we don't have good data on the more modern the more modern emergency contraception, such as ELA-1. Then about hormonal contraception, because this is really the crux of what we're thinking about in the context of ARVs. So the older drugs, you can see represented in with the pink bars, have significant drug interactions. You can see efavirenz there is almost completely pink, so meaning that it is not advised to co-administer with most hormonal forms of contraception. The good news is the newer drugs available are mostly, there is no interaction expected, so are mostly absolutely fine. And I think that has been something that companies have considered when producing new drugs, is that actually drug interaction significantly impaired the utility of the older drugs, and actually means they are probably less used now as a result of that. So really good news to see many drug classes. So all of the INSTIs, there's no drug interaction with hormonal contraception, and our nucleosides are also fine as well. So lots of options there for women who want to use hormonal contraception, as long as we adjust their ART. So what do we think about when we're talking to her? Well, we want to ask her, what form of contraception does she want to use and what is acceptable to her? Also, what will work well given her social circumstances? Does she need female control contraception, or does it not really matter? Is she a sex worker? Is that something that we need to think about as a potential risk for her, and how she might protect herself in many other ways from STIs as well as having contraception? Is she at risk of domestic violence, or is she at risk of not being able to take whatever we give her if it's a pill? So would she be better off with something like an intrauterine device or intramuscular contraception? And then thinking about ART, although we want our patients to be on ART, they may not be, they may choose not to be. And so it's important, if she is starting treatment, that we think about hormonal contraception and the ART that will be compatible with that. But if she's not on ART, we then also need to think about sexual health and STI transmission or acquisition as well in conjunction with that. For women choosing not to use contraception, and that's not something that all women will want. Some women feel very strongly about contraception and don't want to use it, or may want to use a natural method of contraception. The important thing to think about then would be, if you are going to start antiretroviral therapies, having a discussion with her about what are the commonly used antivirals she may be recommended, and how this may affect her pregnancy should she fall pregnant. And this is the Antiviral Pregnancy Registry, which is US-based, and I know Dr. Al-Fashawi has given you a really detailed discussion about the safety of antiretrovirals in pregnancy, and I think it's important to have that discussion with a woman and try and use the safer drugs that we know are being used in the context of an unplanned pregnancy. So that would be first trimester exposure to a drug. And we can see at the top here that lamivudine is the most common drug about which we have information, and the newer drugs are coming in at the bottom. So this evolves all the time and is updated every 6 months, but important to be up to date with it and talk about with your patient. So the other thing to think about, and I know this has been discussed in many sessions, this is really obviously hot off the press, is the BAMO data presented by Rebecca Zash at IAS. And just again, to be familiar with this and to be able to talk to your patient about this, should she want to start dolutegravir, the risk is now 0.2% per 1,000, but is still higher than other ARV choices that she may want to use should she be at risk of conception. So if we look at WHO recommendations, dolutegravir is very significant with regards to first-line prescribing, and there's no specific comment in this box about pregnant women or women wishing to conceive. But it is something that has been thought about, and certainly in the EACTS guidelines as well. It is common practice to discuss with a woman the risk of antivirals that she's starting should she choose not to use contraception, and that may help you both to have a discussion about maybe starting contraception or using a different antiviral combination so that she should be safe. The other thing to think about, but I'm going to start with the premise that there isn't much data. So there was a really good presentation at CROI by so Sharon Hillier was chairing the session. She gave a lovely summary. If you can catch it online, is really good. Thinking about the microbiome. So HIV affects the genital tract, and the genital tract of the woman has the epithelial cells, which act as a barrier to infection or to HIV transmission. And also there are target cells within that epithelial barrier that may increase HIV susceptibility or HIV expression. So we then have the microbiome of the genital tract and hormones, and there's a real interplay between all of these three, as well as potential co-infection with STIs, and also the pH of semen, which can change that whole environment. So all of these interplay, and there's been lots of data looking at what happens if through the microbiome, should contraception be used, and different forms of contraception have been tested. And there's differing data showing that hormonal contraception may change that environment, and that copper IUD may also change that environment. But we don't have any good idea on how contraception then increases a woman's transmission risk. All we are thinking about in this context is HIV acquisition. So I think there's an awful lot more to think about in this context, but we don't have any answers today for this. Again, I know there's a specific talk on women's attitudes to childbearing and talks about stigma. And I think HIV stigma remains a problem worldwide. So certainly externalized and internalized stigma are something we deal a lot with in the UK because we can treat HIV. We know that we can give somebody a normal life expectancy with ART. But what we can't do is always tackle externalized stigma. So that's stigma coming from other people. And that Dr. Ahmed made an allusion about other healthcare workers can also be HIV stigmatizing to people living with HIV, but also internalized stigma. So even if people are being accepted by other healthcare professionals, by their friends or family, there still can be this guilt, this real trauma, this internalized trauma about becoming positive in the first place that can make all of this very difficult to deal with. And it's something we need to think about and address, because women won't always tell us that. They will just think that that's a normal thing to feel, and we'll try and live with it. So thinking about models of care, finally, in the context of HIV, in our clinic in Brighton, we have a clinic called the Sunflower Clinic, where our women start by seeing women's health advisors who can provide counselling, psychological support, and screen for domestic violence or mental health issues such as depression and anxiety. I then provide medical care. We have a nurse who does STI screens and cytology screens, and then we have a specialist in contraception and HRT. And we've been shortlisted for the BMJ Awards for Women's Health Team of the Year. So wish us luck in November, because it was supposed to be in April. It's been deferred. So fingers crossed that maybe we win. That would be really great. But I know in Egypt, where I know this conference is being based, that actually examples of good practice are have been really well demonstrated there. So in response to women living with HIV, saying we need more sexual health services, we need more family planning services, there was a pilot set up to try and do this for women and ran for 3 years. And the subsequent analysis of this data has shown very clearly that women's feedback has been hugely positive, saying that they've been really, really benefited from this project and getting more support about contraception, family planning, being pregnant, and sexual health services. But also the service itself saw 3 times as many women as it was expecting to see. So huge, hugely brilliant example of how working together and actually listening to women with HIV can yield really positive results. So in summary, what I've tried to show you is that there are many contraceptive methods available now. And I think hormonal contraception, where it previously was a no-no, is no longer the case in the context of modern ART, which doesn't interact. A proactive early discussion in the HIV diagnosis, desires for family and therefore contraception choices, is really important. It used to be that HIV treatment was the absolute thing that nobody could change, and anything else had to be modified around that. I feel that is no longer the case, and in fact, ART can be modified to accommodate contraceptive as well as other comorbidity treatment options, and that's something we need to be very flexible with, I think. But also, I think the support addressing stigma, models of care is really important to continue to allow women living with HIV to meet all their medical needs. Thank you very much for listening.
Good evening, everyone. I'm Minna Al-Kutami, Executive Director of the Egyptian Innovation Bank, Academy of Scientific Research and Technology of Egypt. I would like to thank Dr. Yvonne for this informative session on contraception in women living with HIV, the medical recommendations and socio-economic challenges that women face. And now I ask Dr. Sahar Hassani to give us a few comments on this session. Dr. Sahar is Assistant Professor of Tropical Medicine and Gastroenterology at Asyut University. And now, Dr. Sahar, please.
Thank you, Minna. You hear me?
Yes, Susan.
Okay. Thank you for your invitation to this interesting session. And I would like to thank Dr. Yvonne for this very important and interesting talk about the contraception in women living with HIV. I want to ask Dr. Yvonne about her opinion. It is barrier, if she with barrier or with hormonal treatment.
I'm sorry, Sahar, I missed the end part of the question. If it was barrier or?
Do you prefer barrier or hormonal in HIV?
So I think for me, it's actually not even what I prefer. It's very much what the women prefer. And I think that has changed over many years. A lot of women opted for Depo because it was easy. And in the days where the pills for treating HIV were very big and multiple, it was really a good option. So they didn't have another pill to take. So I think women themselves have opt for hormonal contraception. And I think actually that's a really good thing, a very positive thing for them. I think certainly in our clinic, we have large numbers of women going for the Mirena coil because it avoids the menorrhagia and dysmenorrhea of the normal copper coil, but again is female controlled and can see them through menopause. But that's probably the most popular option of women in our clinic. However, for other groups of women, barrier contraception is important, particularly a young woman, so certainly in the UK, in the context of a woman who may not be in a regular relationship, advising condom use is very, very important because what we want to do is make sure that we're protecting are women, but in couples who work together regularly, some couples choose to use condoms as well, although in the context of U equals U, that's becoming less and less common.
Yes, thank you, Dr. Yvonne.
Thank you again, Dr. Yvonne, and thank you, Dr. Saha, for your kind comments. And now we will go for the second session with the UNAIDS presentation by Dr. Sameh. She's going to present attitudes towards health and childbearing among women living with HIV. Please, Dr. Sameh.
Good evening. Could you please stop sharing your screen so I can share? Sorry. Hello?
No, إيه دلوقتي؟
Good evening, everyone. It's a pleasure to join you tonight. I'm going to discuss a little bit the Seizing the Moment report that was just published by UNAIDS at the beginning of this month. And this report is basically a global update for 2020, presenting the different figures and the situation that we have reached. The key information, I'm going to present it very shortly. Basically, globally, we have had tremendous gains in terms of testing and treatment cascade, and more people living with HIV more than ever know their HIV status and are accessing antiretroviral therapy and are virally suppressed. Nevertheless, we haven't met the UNAIDS 2020 fast track commitments, and until now we have 3.5 million people living with HIV who, more infections than we were supposed to have if we had followed the fast track objectives. We have 820,000 more AIDS-related deaths than if the world was on track. And this last year only, we had 690,000 deaths from HIV-related illnesses. 73% of female adults aged 15 years and older had access to treatment. So even though these numbers are considered very positive, it's still very unequal. And gender inequality, denying women and girls the ability to make their own healthcare choices, has highly impacted their response, and especially gender-based violence, which is not always, it's not always measurable in some countries, has been very detrimental to the response to HIV. We also calculated that women who are facing this type of violence are 1.5 times more likely to acquire HIV than women who have not. There has also been some issues in terms of funding due to different economical reasons, or right now due to the COVID, for example. And UNAIDS has estimated that the HIV funding fell by 7% from 2017 to 18.6 billion. So even though these figures look enormous, it's still 30% short of the 26.2 billion needed to effectively respond to the HIV. Some key figures: we have had 1.7 million people who acquired HIV in 2019. So it's more than 3 times the 2020 target, which was aiming at having less than 500,000 people contracting HIV. We have also adolescent girls and young women who account for 1 in 4 infections in sub-Saharan Africa. The report also mentions that in 25 more countries, more than 50% of adults have discriminatory attitudes towards people living with HIV. So this has always also been mentioned previously in the previous presentations. And 62% of new adult infections globally are among key populations and their sexual partners, which is quite shocking since they account for averagely less than 10% of the population. The report also focuses on each region, and I'm going to mention the one which concerns us, which is Middle East and North Africa. So the new infections have increased by 22% from 2010 to 2019. So while AIDS-related death remained stable, we still had an increase in cases. 2/3 of the new infections are among men, mostly men who inject drugs and men who have sex with men. Women living and affected by HIV still remain vulnerable due to different cultural reasons, stigma, discrimination, and also gender-based violence. And they have limited access to services. And also 52% of people living with HIV knew their status in 2019. So while 38% were accessing antiretroviral therapy, less than one-third of them were virally suppressed. If you can see on the slides, we have this figure. So we have the 52% people living with HIV who know their status. So we're still very far, and we still have an enormous gap to reach the 1990 goals, which we are supposed to achieve by 2030. But by now, in 2020, we were supposed to achieve at least 73% of people living with HIV who are virally suppressed and on treatment. So we're not even halfway there. Here you can see the distribution of the new HIV infections by population. So these are the latest estimates. And in in the Middle East, we already have 240,000 people living with HIV as last count in 2019. We had 20,000 new infections. I could go on with the figures, but of course we know that these figures could be doubled and tripled and way more. So only the average is that we have 30% of women accessing antiretroviral medicine. We have 38% of adults living with HIV accessing ARV, and the percentage of children living with HIV accessing ARV is 42%, which has been mentioned as being very shocking by our new executive director, because we're supposed to scale this up. One of the chapters which is also very interesting and relevant to us currently is the synergy between the pandemic responses, especially with the COVID-19 that just recently happened, and HIV. So the HIV response from an experience from the last decades has been very important to respond to the COVID-19 pandemic, and the expertise and the analytical capacity and surveillance and monitoring systems developed through the HIV funding have had great potential to support the COVID-19 response. It has already occurred that in some countries, National HIV Programs Coordinator have been used for their skills in monitoring and research and assigned to countries COVID-19's committees to respond to the crisis. It has been also estimated by a recent report by WHO that if we were to disrupt ARV treatment for at least 6 months, as you can see here on the side, it would cause more than 500,000 extra deaths from AIDS and related illnesses. So the COVID-19 has had an impact already on the HIV response, but due to our experience and knowledge on how to deal with pandemics and the fact that we have had expertise on that, we have been able to respond to that very quickly and to adapt. And my colleague, Dr. Wale, will discuss this a bit later. We have had also the opportunity to turn this crisis not just into a bigger issue, but into a real opportunity. A lot of countries have adapted, and more than 101 countries have decided that they will allow multi-month dispensing of HIV medicines and adapted the services. They have also most of the time adapted their supply chain management in order to avoid stocks out. and also the adapted services for key population, as we have done, and for example, the use of social media in order to reach out to them and for them to reach out to us, the establishment of a hotline, or also the community support in order to reach to the most vulnerable. Another chapter that's very relevant to us is the 4th chapter about securing rights of women. So as mentioned before, violence against women has been very difficult to measure in the last period, especially in the Middle East and North Africa region. So women, they are not only the most vulnerable, but they also very rarely are capable of going towards and they try to get support. So we try to do our best, and I would like to thank Dr. Yvonne for mentioning us before in our project, which I would like to tell you that it has been renewed for another 3 years. So it is definitely an example of best practices for us, and it is highly needed. And the more we work, of course, with women, and we see that more of them come out. So it's not only adolescent girls and young women that are at risk, but it's also pregnant women. And we support safe delivery and try to do our best to get them to follow up on the ARV treatment. I will now let my colleague Dr. Waled, talk and present. Thank you.
Hello, everyone. My name is Wala Ismail. I'm a project field officer at UNAIDS Egypt. And as my colleague Samah has mentioned, that how inequalities are very presented among women and girls who are living with HIV, and that they are considered one of the main vulnerable groups. We can find that women account for more than half the number of people living with HIV worldwide, and young women who age 10 to 24 years old are twice as likely to acquire HIV as the young men same age. And actually, the cultural and societal and economic status in many countries has disproportionately affected women and adolescent girls in terms of access to prevention and treatment, and also sexual reproductive health services. As much has been done to reduce PMTCT or mother-to-child transmission for HIV, but still a lot of efforts are needed to be done in this issue. Next. Okay, so if we are benching why women and girls are particularly at risk for HIV, we have a lot of cultural, structural reasons for this one. As they have late access to healthcare services, and especially young women, and more especially in rural areas where women are restricted to go to healthcare settings by their own, or they need to have their own spouse or partner permission for going for healthcare services, which is still an issue here in Egypt. Also, there's a lack of access to education, women perception of the importance of taking prevention and precautions wisely, and how the education could affect women to take their decisions related to their bodies and choices related to having sex or using condoms, or even using contraception too. Also, child marriage is one of the reasons that makes women more vulnerable for HIV, as also lacks the autonomy to have their decisions related to sexual relationships. And actually, the forms of barriers that for sexual reproductive health, how it affects women. Actually, it affects women in many forms, like denial access to women-friendly services. Like many services are not women-friendly, and they don't have this attitude or atmosphere for women, and providing them a non-discriminatory service without being stigmatizing women over their sexuality. Also, poor quality of SRH services and the low capacities of health providers, as there is no investment in improving their capacities and providing them with trainings to be more able to provide the quality of service that everyone aims. Also, as mentioned before, the consent that's required from the spouse at many times, as women can go alone for healthcare services without taking their husband's permission. So, as one of the major gaps in HIV service provision, it's HIV testing and counseling, which is a vital gateway for treatment service, actually. It's also found that antenatal care is an important determinant of HIV testing, because some studies showed that women who had received antenatal care were more likely to get tested as compared with young women who didn't give birth or attended these services before. Also, antiretroviral treatment for women, still there are some gaps. Unlikely, the general data shows that women living with HIV had access to treatment, like compared to men, like they have 65% access compared to 53% for men. However, AIDS-related illnesses remains the leading cause of this among women of reproductive age. Also, barriers to accessing care that disproportionately affect women, including transportation, lack of gender autonomy, stigma, and economic constraints. This also affects women for taking retroviral drugs and adherence for treatment. Also, stigma from their own community and from healthcare providers is still a barrier for retroviral drugs, and lack of supportive understanding, work environment, lack of employment opportunities, and personal financial resources are also one of the barriers. And again, friendly services for youth and young girls is also one of the main barriers for adherence for HIV or ARTs in general. Okay, when we are viewing these all barriers, most of the strategies came to main components for fighting these barriers and combating these barriers. And the first one is prevention mother-to-child transmission. And as mentioned before, luckily Egypt has succeeded in this issue related to mother-to-child transmission, and that since 2014, none of the children recognized like their mother were been born HIV positive, and they were all HIV negative. Also, integrating healthcare and SRH services in the general and the essential healthcare services is one of the most important components, which will reduce the stigma and the need of taking extra permissions to access to these services. Also, increase male involvement, because most of the we're used to like the programs for women target mainly women, and programs for men target mainly men. But if we have like an involvement of male in women programs, and we're trying to reach men to support the things and otherwise, and provide more like couple support and couple counseling, it could be also a great advantage to improve these programs. Also, one of the barriers that we talked about, the economic barriers, which sometimes hinder women from reaching like the centers and access to services. So for a comprehensive approach for these barriers, we think that addressing poverty and promoting economic empowerment for women is one of the main things. Also, addressing violence and gender-based violence, domestic violence actually affects a lot of women rates of infection, and also using school-based intervention at young age for young girls, which would be helpful also in these programs. Next. Okay, could we move more? Okay. So, as now during COVID, these inequalities actually has been exaggerated and enlarged among women living with HIV. And in this context, UNAIDS had made a lot of effort to respond to the COVID-19 and to help women living with HIV and this situation. So many strategies have been revisited and has been done to ensure the sustainability of services, especially treatment and prevention, and developing new tools for accurate data collection and monitoring and evaluation, including surveys and assessments, and also community mobilization, like involvement in most of the community stakeholders to ensure that everyone is on board. And also UNAIDS has a leading role in previous experience in responding to epidemics and stigma and discrimination. So UNAIDS started to sharing their successful experiences in this issue with other partners, and also fighting inequalities introduced by the new pandemics, which has affected women and young girls in economic and by the constant lockdown situation. Please. So the latest things from UNAIDS, the latest things from UNAIDS has done a lot of assessments and reports to try to analyze on the spot the current inequalities. So shared lessons from HIV for a community-led response had been published. You can find all these documents on UNAIDS website, and also targeting people living with HIV, because some main messages were like directed for people living with HIV, as they are having low immunity and their CD4s are low or their viral load are high, so they are more prone to COVID-19. So it for UNAIDS to disseminate the right information regarding HIV and COVID for people living with HIV to combat these false and misconceptions regarding the increased risk to COVID-19. Also, we have like concrete measures to support women and girls in the context of COVID-19 to ensure that women and young girls have access to health services, SRH services, and HIV treatment and prevention. Also, seizing the moment, which is my colleague Samah has presented a few minutes ago, and we are trying also to mitigate the impact of COVID-19 for key populations and vulnerable groups. Next, please. So, actually, while available data suggests that men experience high rates of COVID-19, women and girls are bearing disproportionate burden of the large impact of the pandemic. Women and girls are not a homogeneous group, and they face multiple forms of discrimination in health services still. While everybody is vulnerable to COVID, people from equally affected by pandemic response, like women, are greatly affected by the pandemic response. And the latest studies has found that women are more vulnerable to the economic effect of COVID, which actually make them in a more vulnerable situation, and they lose their jobs and they have a lot of economic insecurity. Okay, next please, Emma. So actually UNAIDS has worked for the following 6 areas for women to address these inequalities. First one, to address the different needs of women and girls and paying attention to the most marginalized populations. Also to recognize and guarantee access to essential health services, especially during this pandemic. Also address the neglected epidemic of gender-based violence against women and stop misuse of criminal and punitive laws. Also prioritizing adolescent girls and young women's education and health well-being, and values women work and made unpaid work. And for UNAIDS, this comes last thing for us, has responded to the effort during the pandemic. We have made some reprogramming for our project, reaching women, like enhancing women sexual reproductive health, especially women living with HIV and who are affected with HIV. Now we are providing our services in 9 governorates. Include gynecological services and psychiatric services, and we have applied also a hotline to respond to people requests with collaboration with the National AIDS Program. Also now in the process we're having a gender assessment, which is trying to assess the effect of COVID-19 on the socio-economic status of women living with HIV. Also, we are now making our online platform to reach most people, especially who can't access health services, and trying to provide them with needed information and support. And I would like to thank you, and I would like to leave you with this strong message from our Executive Director, Winnie, talking about fighting HIV and fighting COVID-19. Thank you all.
Thank you, Mrs. Samah Said and Dr. Wala Ismail for this informative session from UNAIDS Egypt. And I'll ask Dr. Sahar Hassain again to comment on this session. Thank you, Doctor.
سامعني؟ Thank you, Minna. Thank you, Mrs. Samah and Dr. Wala for this interesting issue and talk. I would like to ask you about the situation in Egypt. You say that the little girl between 10 and 24 years old are more liable to get HIV. What about the situation in Egypt? Culture is different, religion and environment is different. What is the situation in Egypt?
Thank you, Dr. Shakar, for your question. Actually, the situation of Egypt is a little bit, we are having a challenge with collecting data because, as you said, we have a lot of structural and community reflections over women's and young girls' involvement. So actually, we don't have this kind of data for women, for young women, for young girls in this age specifically. That's why we are trying more to target girls in this age and trying to make more friendly services that would help to encourage these young girls to ask for prevention, testing, and also health messages that could help them to reach treatment and testing. So actually, we don't have a lot of data regarding these issues.
Yes, thank you. I think that it is so difficult in Egypt due to stigmata. I want and I wish to collect data about this very interesting issue because cases of HIV is increasing. We see a lot of cases every day in hospital, and patient may know, and she not tell you about this issue. Thank you, Samah and Wala.
You're welcome. Thank you.
Thank you, Dr. Sahar, for your comments. And we have a question for Dr. Yvonne. The question is the use of pregnancy intention assessment tool enough as a starting point for family desire among HIV positive women? Dr. Yvonne?
So, yes, I would say if somebody is expressing a pregnancy desire, that whole conversation should start. But I think actually it should have started before you've even gotten to that point. So a woman is entirely comfortable with what you might be starting to discuss with her. So it's not a brand new conversation, but I think certainly, yes, that is an opportune time to then talk to her about that.
And another question to you, please, is there any experience in involving male partners in low and middle income countries in addressing stigma and desired family size discussions at ART start?
I think that's a really brilliant question. And actually, I think it's something that not only affects low and middle income countries, but it also affects higher income countries. So the UK has had non-government organizations come in and actually try to engage men of women who, the male partners of women who are positive in testing in the East End of London. So I think there isn't a lot of data on this, but I think it's hugely important to try and reduce stigma, to address this as a couple, as a family, so to try and break down the barriers. But I think it's easy for us to potentially say that, but for that to be really active for that woman, I think we have to individualize that and take that at her own pace. So it's slowly, I would say, for some women, but for others, it may be easily broachable at the first point to get her male partner involved. So the answer to the question is no, I don't know of any data in low and lower middle income countries, but also I know there is need in higher income countries based on the data that we have.
Thank you, Dr. Yvonne. Our next question is for Mrs. Sameh and Dr. Wale. What strategies does the region have in place to involve men in prevention of mother-to-child transmission, HIV activities, and school-based interventions?
Excuse me, could you repeat the question?
Okay, sure. What strategies does the region have in place to involve men in prevention of mother-to-child transmission, HIV activities, and school-based interventions?
Actually, there are still some kind of activities running around, but for Egypt now, there are less activities related to male involvement and school-based interventions. Some other organizations have started some dialogues about having like a comprehensive sexual education in schools, and they interviewed both parents and like women and men, and actually I don't know if the results are published yet or not, but what I knew that it wasn't very welcomed through the focus group they had, that to have school-based intervention for reproductive health. So I think now we need to focus more on these efforts and for male involvement, including like couple counseling and design parallel messages for both women and men to be on the same page, instead of like just starting women in women projects and to have both partners involved.
Okay, I would like to thank our speakers, Dr. Yvonne Galis, Mrs. Sameh Sayed, Dr. Wala Ismaili, and of course, our Dr. Sahar Hassani for this session. Thank you all.
Thank you very much.
Thank you.
Thank you.
We'll take a short break and come back. We'll start now our next session with Ms. Swami Jallo. She's ITPC's Director of Global Programs and Advocacy. And let me introduce ITPC. It's International Treatment Preparedness Coalition, which is a global network of people living with HIV, community activists, and their supporters, working to achieve universal access to HIV treatment and other life-saving medicine. And we will have as a commentator on this session, Dr. Ahmed Saad. He is Professor of Internal Medicine and Infectious Disease. We'll go now with Ms. Kwame. She's going to talk about updates about HIV and women's health from major Congress and impact of COVID-19 pandemic on women living with HIV. Please, Kwame.
All right. Thank you very much, and good evening to everyone. Thank you to my fellow panelists who've made some very brilliant presentations so far. A lot of the reflections that they've made resonate in the presentation I am about to make. My name is Wame Jalwa, and I'm Director of Global Programs with International HIV/AIDS Preparedness Coalition. I'm making this presentation on behalf of women living with HIV, vulnerable to HIV. And as you can see from my presentation, there have been several authors of the views that I'm presenting before you. This presentation was made at CROI as well as the AIDS 2020 conference. And then advocacy brief will be made available to everyone just to sort of dissect sort of the views that came out of the study that we did. So thank you, Mena, for introducing ITPC. In the interest of time, I won't really dwell on this, but it's just to say that ITPC's mission is to enable people in need to access optimal treatment. And this is from a global perspective and global voice on treatment access issues. We have 3 strategic pillars: Watch What Matters, which looks at empowering communities to collect data; Make Medicines Affordable, which really supports advocacy around eliminating intellectual property barriers, but also ensuring that affordable medicine is available in country; and Treat People Right, which its mission is to ensure that treatment education is provided to communities and empowers the advocacy that we do. So who am I representing today in terms of this presentation is women living with HIV and also vulnerable to HIV. We did a key informant interviews between December to February 2019 to 2020. And this was in collaboration with Salamander Trust, ICW East Africa, Africaid, and we surveyed 198 women living with and vulnerable to HIV. And the focus of the data collection was in 4 key areas. One was around rights, inclusion, access to services, and research. And a lot of the findings that you see in the presentation today represent 28 countries globally. And you can see at the bottom, that's the list of the countries that were represented in the study. We did several types of processes to the study. So we did an online survey, which we managed to reach 57 women and girls aged 14 and above living with and vulnerable to HIV. We did a series of focus group discussions in Uganda, South Africa, and Zimbabwe, also targeting the ages of 18 to 24. We did key informant interviews as well. And the women who responded to the survey represented all diversity. So women who use drugs, sex workers, women who were married, single, divorced, women who were employed and unemployed as well, etc. So we'd really tried to ensure that the sample size that we used in the study was quite representative. Let me just take a pause and reflect on some of the reports that have been mentioned during this discussion, but also during the conference. The first one is from the Executive Director of the UNAIDS, Winnie. She made a statement in the latest 2020 UNAIDS report, We've Got Power. And her statement was quite powerful. She says, the HIV epidemic holds a mirror up to the inequalities and injustices faced by women and girls, and how the gaps of rights and services are exacerbated by the epidemic. This is unacceptable. This is avoidable, and it must end. Women and adolescent girls are demanding their rights, and governments must act on those demands by providing resources and services to protect their rights and properly respond to their needs and perspectives. I think this is really important as we reflect on the feedback that we get from women around access issues to not only sexual and reproductive health services and rights, but also HIV as well. I'd like to just reflect on the fact that it's now, this year marks the 25th anniversary of the Beijing Declaration, where we explicitly noted that the recognition and reaffirmation of rights of all women and the control of all aspects of health, in particular fertility, is a basic right of empowerment. And that's really an important reflection as we look at what women have said. Looking at the World Health Organization consolidated guidelines on sexual and reproductive health rights, especially for women living with HIV, and there's a checklist that was made by Salamander Trust. It acknowledges that women living with HIV face unique challenges and human rights violations related to their sexuality and reproduction within their families and communities, as well as within healthcare institutions where they seek care. They stipulate that services must be women-centered, accessible, acceptable, affordable, and a basic human right to and gender equality, and meaningful involvement of women living with HIV and vulnerable to HIV in all programs and policies and how they affect their lives as well. And that's really important reflection as we look at the findings. I'd like to just take a moment to look at the context behind the findings, in particular looking at sub-Saharan Africa. In 2018, we note that there are 19.6 million adults living with HIV in sub-Saharan Africa, but 12 million of those are women. 7 out of 10 women in sub-Saharan Africa do not have comprehensive knowledge of HIV. And that's the foundation of a lot of ITPC's work, is really demonstrating how treatment education really empowers an individual to make the right choices around their health. 4 out of 5 infections are among adolescents aged 15 to 19, young girls, and young women aged 15 to 24 are twice as likely to be living with HIV than men. Although access to ART is improving, there still remains a lot of critical gaps around how women living with HIV, both globally and within sub-Saharan Africa, where only 68% of female adults aged 15 and older have access to treatment. And that's something that we need to consider in the way that we program and we provide services for women and young girls. In 2018, thanks Dr. Yvonne for reflecting on it, the NTD from dolutegravir was actually cast as a harsh spotlight to some of our chronic challenges around SRH and HIV access for women. And it really pointed out to the fact that access to and quality of SRH services and rights for women and young girls vulnerable to and living with HIV, particularly those aged 14 and 59, there were some glaring gaps. We saw that there were a lot of resulting policy and access fallouts, including national-based, sex-based treatment restrictions for women and young girls. And this really underscores the need for meaningful involvement of women living with HIV in the design, development, implementation, and oversight of not only just the programming, but the research policies and services that are provided as well. In South Africa, unfortunately, in February 2020, there was a reflection done by the South African Commission of Gender Equity that reported that nearly 50 women living with HIV were coerced and forced into sterilization in public hospitals, while in extreme pain before giving birth. These women were told that they would not receive medical attention unless they signed a consent form without explanation of what the form and consequences of signing it was. And this has to honestly stop. Just taking a step back and reflecting generally, globally and particularly in sub-Saharan Africa, access to and quality of essential sexual and reproductive health rights and services are complicated by gender, socioeconomic, geographic, provider and facility level, structural and other barriers, including limited choice, lack of information, stigma and discrimination, which has been highlighted in many of the presentations before me, especially for the younger unmarried rural women, female sex workers, or women living with HIV or who use drugs. So just reflecting on some of the findings that we had amongst women, and this came out of key informant interviews in the 28 countries. They reflected some of the service barriers in terms of rights, inclusion, and access as follows. The stigma and discrimination still prevails in many of the public health settings, especially for women who are young or single, in same-sex relationships who use drugs, women who are female sex workers and living with HIV. They expressed the issue of lack of integration of SRH and HIV services and having to travel very long distances to access services. there's a quote that says, some women cannot afford to go to another clinic on another day. When they think about who they will leave their children with, they just don't go, and they end up becoming pregnant. There was an issue around lack of privacy and confidentiality. One of our respondents actually noted that they felt violated in their privacy. They had a group of 20 student nurses who came around to watch how an IUD was actually removed, and they felt, this was not a good setup in terms of privacy and confidentiality. There were issues of consent that were also raised. One of the respondents actually noted that I was told that I'm too young to access services. In plain terms, I'm likely to be a disgrace to my community. So we need to really think around, how do we provide services for young people who actually want to access condoms, want to access sexual and reproductive health services under the age of consent, and how we can involve their parents and guardians in that process. Healthcare workers there was a issue around how healthcare workers have challenges inserting and removing long-acting reversible contraceptions, the LARCs. There was a quote that we had from a particular woman that said, I have just become a champion of IUD, and I'm convinced that other young women to take it up as a family planning method. But all the women have told me lies, that the IUD will burn up all your ovaries and eggs, and you will not be able to give birth in the future. That family planning will make you look so bad to men, and you will not be able to look at you in the future. And this really stresses the importance of treatment education and how women understand what are the family planning methods that are available, and how they can access them. LARC is not very readily accessible, and women do not have adequate information about it either. There was another issue cited around family planning messaging and the agenda that differs from the needs and priorities of women living with HIV. They felt that they will coerce you to use what they have instead of telling you what other methods you want that is out of stock, or administer expired drugs. The healthcare worker will ask basic questions like, how many children do you have? And then decide what to give you, as opposed to having an informed consent point of view. And this is something that was raised by the women in terms of needing a process that was complete, not judgmental information that leads them to make a decision around informed choice of contraceptive and use. There was also feedback around structural violence in healthcare settings, that some of the service providers were deemed as often very judgmental, especially around having children, wanting children, living with HIV, and wanting to have sex without children. Most of the providers, as quoted here, have mentality that if you're living with HIV, why would you want to start a family? So a lot of people were denied the right to even start a family, even if they wanted to. There was a lot of feedback that we received around the need for non-judgmental counseling in the absence of family counseling services. There was also feedback that we received around dual protection, that women living with HIV are concerned around onward transmission and being able to avoid pregnancy or planning for a family. Yet a lot of the service providers rarely have or take time to discuss options that would enable women to decide on the mixed methods that were available. They reflected around contraceptive options, not only from a price point of view, so what was the cost? So yes, condoms are free, but beyond that, many of the other services are not. Availability of the different methods, and also the views of the service providers in terms of outlining and sharing with women to say, these are the options that are available to you. Service providers are often under pressure to meet their targets in terms of contraceptive distribution to ensure their organization meets funding, but not actually looking at how does it meet the needs of women as a whole. Some of the strategies, they were concerned that the donors are not funding them, or acknowledge that they're important to women living with HIV, and how do we ensure accountability, not only from a government point of view, but also from a donor point of view, that we adhere to the WHO Sexual and Reproductive Health Rights Guidelines for women living with HIV as well. One of the very strong points that were made around women leading the way. There was a lot of feedback to say that, there's a lot of really good work that women are doing on the ground to ensure that the rights and services of women and adolescents are actually met according to WHO's guidelines. But the biggest gripe that they have was that these services, policies, and programs are not always available and are not always led by women. So how could we actually change this going forward? There was some reflections around some gaps around even the research aspect. There've been a lot of clinical trials, but what's glaringly visible is that of the clinical trials, less than 20%, for example, if you take clinical trials from 2013 to 2003 to 2013, a lot of those clinical trials did not actually have females as a large part of their cohort. Less than 20% were female. And this actually is quite a stark finding, in consideration that a lot of the policy and services that are actually designed are for the benefit of women. And some of it was reflected in the ECHO and what came out of the ECHO. It's not until 2019 that the answer to a fundamental question, whether certain types of contraception increase risk amongst women, became available. And this is through the ECHO trial. And the ECHO authors actually strongly emphasize that the need for more aggressive HIV and STI prevention and management efforts of African women, including PrEP and HIV prevention, needs to be integrated into contraceptive services. So taking a step back, a lot of the women reflected that the research felt very top-down, biomedical, male-dominated. So a quote says, "This feels like a male-dominated male sport." The second female condom came with a sponge. Who approved that? Who thought that it would be comfortable to insert or use as well? If women were consulted, take for instance in the US, if they would have looked at African-American women, Latino women, and find out that what they really want, not that women will take what is there. That's not right. There's much research needed about rolling out contraception for women. The women that were interviewed really play a key role in ensuring that information on the latest research on family planning methods is provided to women, and it's important to include them as we move forward in the policy direction. So just sort of skipping ahead on the presentation, I just want to highlight some of the next steps that were done by a few agencies. So for example, the International AIDS Society has come up with a framework that looks at what are the opportunities for us to leverage differentiated service delivery, especially looking at ART to strengthen family planning care. And a lot of the advocacy components that were reflected in it are a part and parcel of the recommendations that our advocacy brief also provides, which is, really is important to engage women and girls living with HIV in not only policy design, but also service delivery as well. We need to utilize differentiated service delivery referrals and follow-up as an opportunity for continuity of family planning care. We need to think about how we promote the use of long-acting reversible contraceptives amongst clients in ART, in DSD, ART, and align contraceptives and ART resupplies in different ART methods. And really, at the end of the day, look at what are the opportunities for integration and how that helps us to reach a lot of people that we often struggle. There were some recommendations that women gave based on some of the experiences, which include, the meaningful involvement of women living with and vulnerable to HIV in policy development and design. They don't want to just be at the end line where they're just receiving the services. They want to design the services that are meant for them as well. And that's really important and strategic. In terms of research, we really need to ensure that more women are included in the cohort of research. And that would really help us begin to prioritize what their needs are, particularly for family planning methods as well. We really need to start thinking about integration in a very strong way, not just for HIV and SRH, but also other services and other disease areas like opportunistic infections and non-communicable diseases as well. We need to ensure that there's full access to non-judgmental information. And ITPC's framework has always been treatment education is the foundation for anyone to be able to make informed choice. And as long as you're not empowering the individual to understand what the information is, what is available to them, what are the standards of care, they will not be able to make the right type of decisions around informed choice. So it starts there. And then providing a one-stop shop where whether it's SRH and other integration of services, especially for people living with HIV, how can we integrate the services that actually look at the person as a whole as opposed to just very disease-specific areas as well. We need to support more SRH services and programs and structures based on women living with HIV. And at the end of the day, make sure that SRH, we understand that SRH and HIV services are a basic human right. So issues of confidentiality, accessibility to women and as an adolescent girl, non-judgmental services, friendly services that are don't have high user fees that act as barriers are part and parcel of how we construct our service delivery on the ground will really go a long way in terms of really making sure that people who are lost to follow-up actually access services. We need to make sure that women are included in clinical trials so we understand what the needs are and able to program from it at the end of the day. And the research results are able to help guide us in that sense as well. There are two sort of last thoughts that women prompted from our discussions, which is that women's advocacy, peer mentoring, community work is valuable and should be supported 100%. We need to empower more women to actually be at the forefront of service delivery and planning and programming as well, and make sure that there's a link between SRH, gender-based violence, gender equality needs to be brought to the forefront of our programming as well. So thank you very much, everyone, for listening. We're happy to share more views, but just to acknowledge the different organizations that were part and parcel of some of the thoughts that came across in this presentation. And thank you to my panelists for also sharing some of those thoughts as well. Thank you.
Thank you, Wami, for this informative presentation about HIV and women's health. And I'll ask Dr. Ahmed Saad now to give a few comments on this presentation.
Now, I'll introduce now Dr. Chakron, or just we'll have a discussion with Dr. Wami.
Short discussion with Dr. Wami, please.
Wami, yes.
Yeah, very good to have a chance to reach to this population of very low socioeconomic standards, and they gave this excellent service. It's for humanity. It's very important discussions for the HIV patients, and to have the medicine and to have the advice for them is very good and excellent to choose regarding the also the options of the prevention of also the conception and to have an HIV medications. All these are very nice, and thank you so much.
You're very welcome. Thank you.
Thank you, Dr. Ahmed. Thank you, Wami. And now we are proceeding to the next lecture with Professor Chakron. He is the head of the Department of Infectious Diseases at Fatuma Bourguiba Teaching Hospital at Monastir in Tunisia. And he is a national and regional consultant on HIV AIDS, who had participated a lot to a lot of the trainings for HIV management in all the region, and especially in Egypt. So we are very happy to welcome him, and I'm still welcoming Professor Ahmed Saad, my professor at Cairo University, professor of veterinary medicine and infectious diseases, as a commentator for the coming session about the human papilloma virus, skin lesions, and cervical cancer screening.
It's an honor for me to introduce Professor Dr. Mohammad Chakron, the professor of the infectious diseases and head of Department of Infectious Diseases at Fatuma Bourqiba Teaching Hospital in Monastir, Tunisia. We are honored to have you with us, Dr. Mohammad Chakron. He will speak to us about the human papilloma virus-related skin lesions and cervical cancer screening. Please, Dr. Chakron.
Thank you. Thank you very much. Good evening, everybody, and thank you for this introduction and for the organizer for this invitation in this meeting. I will talk about HIV and co-infection with one of neglected sexual transmitted infection, I think. So, sorry. Human papilloma virus is the most common viral infection of the reproductive tract, and most sexually active women and men will be infected at some point in their lives, and some may be repeatedly infected. And the people living with HIV are at most risk of this infection, and this infection may cause more complication, especially when the immune system is weakened. In the era of effective antiretroviral therapy, the diseases related to HPV infection are stable or continue to rise, especially in people living with HIV, with higher risk of genital cancers, compared to the general population. So, optimizing screening, prevention, and treatment of diseases related to HPV should be considered as high-impact public health intervention. So, what is HPV? Human papilloma virus corresponds to a group of viruses that are extremely common worldwide and affects only human. HPV is DNA virus from the papillomaviridae family, including more than 170 types, and some types of HPV are carcinogenic. HPV may be spread through sexual contact and infect the anus and genitals. Penetrative sex is not required for transmission. Skin-to-skin genital contact is well-recognized mode of transmission. And there is no evidence that HPV can spread via common items like toilet seats, but the types that cause warts may spread via surfaces such as floors. And people can become infected with more than one type of HPV. Also, HPV infection can spread from mother to baby. But the risk of mother-to-child transmission of HPV during pregnancy or childbirth is very low. And even if baby do get the HPV, their bodies usually clear the virus on their own. And no link has been found between HPV and miscarriage, premature delivery, or other pregnancy complication. Most of the time, a baby born to women with genital warts does not have HPV-related complication. So, mother-to-child transmission of HPV should not be a concern. What are the clinical aspects of HPV? So, about 90% of HPV infection cause no symptoms and resolve spontaneously within 2 years. However, in some cases, HPV infection persists and results in either oral papilloma, warts, or a precancerous cervical lesion. HPV infection is the primary cause of cervical cancer, and it is also associated with genital cancers as well as growing number of head and neck cancers. Although the majority of HPV infection are usually benign and resolve without clinical signs or symptoms, some infection persists and can progress to pre-cancer and, if left untreated, to cancer. So The main manifestation or aspects, clinical aspects of this viral infection are mucosal lesion and cutaneous lesion. And there is some correlation between types and manifestation of this infection. For example, 15 types of HPV are recognized as high risk of cancer or cancer-causing genitals, and especially 16 and 18 types are more prevalent and more causing cancers, but other 13 types of HPV may cause cancers. And some other groups with low risk of cancers and may cause respiratory and laryngeal papilloma, low-grade abnormalities of mucosal cells and genital warts, and other may cause common warts in hand and feet. So we can distinguish two groups of HPV. The first one is cancer-causing genital HPV types, including 15 high-risk types, and together HPV 16 and HPV 18 cause about 70% of cervical cancers worldwide. And the second one is benign, the most common low-risk mucosal HPV type, including 6 and 11 type, and together cause about 19% of genital warts. So let's focus now on sexual infection. The peak time of acquiring infection for both women and men is shortly after becoming sexually active. And HPV infection usually clear up without any intervention within a few months after acquisition, and about 90% clear within 2 years. And there are many types of HPV, and many do not cause cancers. And a small proportion, less than 1% with some types of HPV, can persist and progress to cervical cancers, especially, as I mentioned, types 16 and 18. The main risk factors for persistent infection by sexually transmitted types are early age of first sexual intercourse, parity and young age at first birth, multiple sexual partners, co-infection with other sexually transmitted agents as herpes simplex virus, chlamydia, gonorrhea agent, tobacco smoking, and poor immune function as people who are immunocompromised, such as people living with HIV, are more likely to have persistent HPV infection and more rapid progression to pre-cancer and cancer lesion. So HPV infection in women is peaks around 25, and after which prevalence tends to decline, likely due to the natural clearance of the virus from the body. But the prevalence of HPV vary widely between regions. For example, in sub-Saharan Africa, the prevalence is 24%, Eastern Europe countries 21%, and less prevalent in Latin America 16%. So HPV is cancerogenic virus, and about, as I mentioned, about 15 serotype as with high risk of developing cancer. Cervical cancer is by far the most common HPV-related disease, and nearly all cases of cervical cancer can be attributable to HPV infection. The infection with certain HPV type also causes a proportion of cancer of the anus, vulva, vagina, penis, and oropharynx, and which are preventable using similar primary prevention strategies as those for cervical cancer. Cervical cancer is caused cervical cancer is caused by sexually acquired infection with certain types, and as I mentioned, 16 and 18 types cause 70% of cervical cancers, And this cancers, the cervical cancer is the second most common cancer in women living in less developed region, and about 90% of the death related to this cancer occur in low and middle income countries in 2018. What is the link between HPV and HIV? There is a close link between the two viruses. The overall risk of HIV acquisition among women is doubled when they have had HPV infection. And for women living with HIV are more likely to have persistent HIV infection and more rapid progression to precancerous lesion and cancer. So, among women living with HIV, HPV prevalence rates are even higher in the countries with the highest burden of HIV, reaching level as high as 80% in Zambia and 90 to 100% in Uganda. The risks of genital cancers are higher in people living with HIV compared to general population. For example, for anal cancers, 29 times increased risk, in penile cancers 4 times, and for vulval and vaginal cancers as well as cervical cancers 6 times. So what about cervical cancers and HIV? The cervical cancers is the 4th most common cancers among women worldwide. And the cervical cancers is the most common cancers among women living with HIV. And the likelihood that women living with HIV will develop invasive cancers is up to 6 times higher than for women who is not living with HIV. So although most HPV infection clear up on their own and most precancerous lesions resolve spontaneously, there is a risk for all women, especially for those with risk factors, that HPV infection may become chronic and the precancerous lesion progress to invasive cervical cancer. And it takes 15 to 20 years for cervical cancers to develop in women with normal immune systems, but only 5 to 10 years in women with weakened immune systems, such as those with untreated HIV infection. And this period can be used for screening and prevention. And now we have more and more recent complete information about papilloma virus infection in women living with HIV. And I would like to share with you 2 recent cohorts coming from, the first one coming from, coming from Brazil, about 325 women living with HIV. And the prevalence of high-risk HPV infection was about 31%. The most prevalent high-risk HPV virus, HPV types were 56, 59, 66, also 30, 35, 39, 68, and 52, 16, and 45. And among the women with high-risk HPV infection, about 43% had multiple infection, and the prevalence of high-risk HPV type among women with cytological abnormalities was high, about 90%, and about 60% of women living with HIV with CD4 cell count less than 200 showed the highest prevalence of high-risk HPV. The second cohort coming from Canada in 2019, and the pre-vaccination HPV 60 and 52 were the most prevalent oncogenic HPV types. 45% were infected with at least one oncogenic HPV type. 33% of participants had a persistent oncogenic infection, and HPV 16, 45, and 52 were the most frequently persistent type. And also, in this cohort, lower CD4 count was significantly predicted HPV persistent. So what we can learn from this recent publication that unvaccinated women living with HIV were infected with a wide range of oncogenic HPV types. Abnormal cytology are more prevalent with high risk non-target vaccine, high-risk HPV, and the low CD4 cell count was an important determinant of HPV infection and abnormal cytological findings. So what is needed? What should be done is to continue initiating optimal ERT according to 90-90-90 to test, to treat, and to retain in care, and to reach viral suppression. To continue advocacy for HPV vaccination, and current HPV vaccines might not offer protection against all high-risk HPV types, and to implement and strengthen cervical cancer screening. So why to screen? Because of a risk of HIV acquisition among women with HPV is doubled. Invasive cervical cancer developing is higher for women living with HIV. HPV infection also are more likely to persist in this population, and low CD4 count reduce the clearance of HPV. Why to screen? Also to detect abnormal lesion, to detect infection, inflammation, to follow up if abnormal test, and to check for abnormal cell changes or recurrence of cancer after treatment. How to screen? We can use via test, visual inspection acetic acid, PAP test or HPV test, and to access to cervical cancer screening for women living with HIV is very limited, and many guidelines of HIV care in our region, for HIV care and treatment don't recommend HPV infection screening. So how to screen? The first one is visual inspection with acetic acid, and this test may show opaque and white aspect. This is in this picture, and when the test is positive, it can guide some biopsy. Papa Nicolau or PAP test to find cell changes or abnormal cell in the cervix. And the PAP test is a very good test for finding cancer and cells that might become cancer. And HPV test checks for the virus, not cell changes, and the test can be done at the same time as the PAP test with the same swab or a second swab, may allow a determination of the type. And the women having HPV negative tests are not at risk for developing cervical cancer in the next 5 to 10 years. And the considerable advantage of this test is the women can perform it themselves, so it is a self HPV test. So what recommended is a PAP test plus HPV test. It's called co-testing, and is the preferred way to find early cervical cancers and precancers in women 3 years and older. We can also recommend a colposcopy to obtain a cervical biopsy to confirm diagnosis of cancer and to initiate the treatment. So what WHO recommend? HPV test, when positive via test, when via test negative, first screen after 1 year, positive cryotherapy plus loop electrosurgical excision procedure, and if suspicion, refer to appropriate diagnosis and treatment. And when HIV test is negative, we rescreen after 3 years. So how to prevent? We prevent with vaccination, with cervical cancer screening, with condom use, with sexual counseling, and with circumcision. And how to prevent? There is primary prevention. We target here girls from 9 to 13 years with HPV vaccination, with health information, sexuality information, condom promotion, and voluntary medical male circumcision. After that, secondary prevention starts in women with 3 years of age and old, screening and treatment as needed, and the tertiary prevention, all women as needed treatment of invasive cancer at any age. Vaccination. About vaccination, there is 3 vaccines actually available. Bivalent vaccine with 2 types, 16 and 80s, excellent safety and immunogenicity profiles with long-term protection. The quadrivalent vaccine, including 16, 18, and 6 and 11. And 16, 18 are at high risk for cervical cancers, and 60 and 11 for high risk of genital warts. And the recent one is nonavalent vaccine with the 4 previous serotype plus more 5 serotypes with high risk for cervical cancers. So how to prevent? Clinical trials and post-marketing surveillance has shown that HPV vaccines are very safe and very effective in preventing infection with HPV. HPV vaccines work best if administered prior exposure to HPV, and the vaccines cannot treat HPV infection or HPV-associated disease such as cancer. WHO recommends to vaccinate girls aged between 9 and 14 years. Some countries have started to vaccinate boys aged 11 to 12 years, as quadrivalent HPV vaccine also prevents genital cancers in males, and a significant reduction among vaccinated women of both HIV prevalence and cervical abnormalities were observed. So vaccination vaccines is effective method of primary prevention of cervical cancers. Notably, the HPV vaccine are available, but not for everyone, and just 10% of girls in low and middle income countries access to HPV vaccine compared to 19% in high income countries. So how to vaccine? For immunocompetent 2 dose for young women less than 15 years at the beginning and 6 months after, and for immunocompromised 3 doses, the first one 2 months after and 6 months after. What we need to prevent cervical cancer in women living with HIV: to screen HPV skin lesion at each visit, recurrent screening of cervical lesion, and this should be included in national guidelines as part of comprehensive HIV care, and continue advocacy to convince decision maker of the benefits of HPV immunization. So in conclusion, HPV infection are common and sexual transmitted infection. HPV infection are often asymptomatic or induce a skin lesion, and untreated infection caused by some types of HPV put women at high risk of cervical cancers. There is a strong link and a close link between HIV and HPV, and unvaccinated women living with HIV were infected with a wide range of oncogenic HPV types, and an optimal antiretroviral therapy and continuous cervical cancer screening are key steps toward the global elimination of cervical cancers. Cervical cancers is preventable and curable if early diagnosed, so it's time to implement an efficient HPV prevention based on HPV immunization, screening of cervical cancers, prevention of precancerous lesion. I would like to acknowledge my assistant for help on this presentation, and thank you very much for listening.
Thank you so much, Dr. Chakroni. Very excellent and elegant lecture. Just one question regarding the human papillomavirus vaccine. in our area in the Middle East, and vaccinating a child with human papilloma virus as if this is sexually active or whatever. But it has been extrapolated the data that almost 350,000 cervical cancer will be diagnosed in the Middle East, North Africa region, with almost 50% mortality in year 2035. So they are now pushing for the vaccination of the human papilloma virus. And the last ACIP recommendation, or the Advisory Committee of Immunization Practices in the States, to vaccinate between 13 and 27, up to 40 years of age. This is the last ACIP statement. This is number one. Number two, for Immunocompetent, the state also 3 doses, 016, as you state, for 3 doses for the Immunocompetent. So my question, there has been data of the transmission of human papilloma virus by swimming pools and non-sexual routes to convince the families to vaccinate the young girls and to prevent the cervical cancer. What's your opinion regarding the non-sexual transmission of the human papilloma virus and the age between 13 and 27?
Thank you for this question. I think we are not doing enough in our region for screening and also for vaccination. And many countries in our region don't recommend this vaccination because the cost of the vaccination, the cost is high, especially for the last one. The non-violent vaccine is very, very expensive. And this non-violent vaccine is more effective because there is a large wide range of high risk types of HPV. So I think I don't see that we have comprehensive data in our region about vaccination, about also genotyping, and about the transmission of HPV. And as I mentioned, many guidelines in our region, and here I would like to focus on guidelines of HIV care and treatment and prevention. Don't mention screening of HPV infection for women living with HIV, and don't recommend also vaccination. So I have a poor data on vaccination in our region, and we have also less information about the transmission of HPV, sexually transmission of HPV in our region.
Thank you.
Now I'd like to welcome Dr. Sami Zaki. He's one of our chairpersons for today's meetings. He is professor of hepatogastroenterology and infectious diseases at Al-Azhar University. And I'll give him the floor to introduce our last speaker for today, Dr. Mohammad Munir. Please, Doctor. Dr. Sami?
Sami, unmute mic, please.
Bismillah ar-Rahman ar-Rahim. I am honored to introduce my dear colleague and brother, Professor Dr. Mohammad Munir. He is an eminent figure and leader in HIV group and was head of HIV department in Abbasiyya Fever Hospital. I am also honored to be with my dear brother, Professor Dr. Ahmed Saad in this session. I also honored to be with all of you. Professor Dr. Mohammad Munir will introduce an important lecture about a special situation in women living with HIV, about her bone health and if it need to special care or not. Thank you. Professor Dr. Munir.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. شكرا للجنه المنظمه وشكرا لاستاذنا الدكتور سامي، دكتور احمد كردي وجميع الزملاء for allowing me to give this presentation. In fact, why we have to give care with women living with HIV, because as mentioned by other speakers, they represent more than 50% of people living with HIV globally. And in addition, worldwide HIV/AIDS is the number one cause of death for women of reproductive age, and even the number is higher in sub-Saharan Africa, may reach to more than 60% of infected population are women, and especially in particular the age group of 15 to 24, we can find that they are more susceptible to have the infection 8 times than their peer adult males. Actually, treatment for them is not enough to erase the possibility of having risk due to non-communicable disease. And this chart shows that non-AIDS mortality after first year of treatment was higher than after that. And we do not aim just to bring the people living with HIV to diagnosis and getting antiretroviral therapy, but we aim also to keep them retained in care. Keeping them retained in care means that we take care of them from all aspects, not only from the HIV aspect, but because they are aging, we have to take care of the whole case together. As you see in this chart, people living with HIV are aging and face increased dangers of non-communicable disease such as cardiovascular disease, including hypertension, hypercholesteremia, myocardial infarction, strokes, diabetes, chronic kidney disease, osteoporosis, and non-AIDS malignancies. And some patients come to us not only with HIV, but with 1, 2, or 3 comorbidities. The pathogenesis of chronic complication of HIV are having 3 aspects. The patient aspect as living in the community, getting the risk as other population, with high rate of traditional risk factors such as smoking, dyslipidemia, hypertension, diabetes, obesity, and from the viral aspect, because HIV makes the patient in a continual inflammation and immune activation, and from the aspect of ART with its adverse effects and toxicities. We will start with a very important topic, osteoporosis. HIV infection and some HIV medicine may increase the risk of osteoporosis in people with HIV. Certain lifestyle and hormonal factors which increase the risk of bone loss are prevalent in patients with HIV. These include physical inactivity. They are a little bit lazy, suboptimal intake of calcium and vitamin D, cigarette smoking, sometimes alcohol or drug use. And in addition, there is a studies prove low testosterone levels in males living with HIV. The osteoporosis is a skeletal problem and characterized by low bone mass, which predisposed to an increased risk of fracture. Osteoporosis and osteopenia defined by WHO, and osteoporosis means brittle bone. Porous bone means brittle or weak bone, and the osteoporosis is an important public health problem, especially that the osteoporosis costing too much for treatment, especially with pelvic fracture and also hip fracture, and sometimes it leads to death due to the vertebral fracture. In fact, the case is associated more with the lowered CD4 count, especially at the beginning before treatment. The ART contributes to loss of bone mineral density, with the greatest reduction in bone mineral density during the first 2 years. على عكس المتصور في كثير من الأحيان إن الناس تظن إن osteoporosis will come with a prolonged duration of treatment. It's appearing more in the first 2 years of treatment. HIV infection and use of ART, particularly regimes that containing TDF, increases the risk of premature bone loss and exacerbating the risk of osteopenia and osteoporosis. The study of about third of people living with HIV population in Japan, more than 3,200 cases, suggested an association between osteoporosis-related fracture and the duration of the TDF administration. The patient with longer duration of TDF exposure have an increased risk of the bone fracture. And if the duration of TDF administration is more than 5 years, the possibility of bone fracture must be considered regardless the age and the sex of the patient, according to IAMI 2018. We here look to the chart of the sub-study that proved the same idea. Greater bone mineral density loss was associated immediate treatment versus the deferred ART in people with living with HIV. When 2020 found the treatment-naive HIV-infected individuals who started their treatment with TDF-containing regime continue to have bone mineral density loss at 5 years, even though the rate was more during the first 2 years, as we mentioned before. In addition, lower pre-treatment CD4 count was associated with loss of BMD, as we mentioned earlier. It is hypothesis that the damage may be due to complex interaction of T cells with osteoclast and osteoblasts, likely influenced by both HIV itself and the ART. Since osteoclasts are required for maintenance, repair, and remodeling of bones, infection of osteoclast by HIV leads to its differentiation and most likely contribute to the osteolytic disease in HIV-infected patients. It has been found also that some proteins in the structure of the HIV itself can affect this process. For example, the HIV GB120, the envelope protein of the virus that binds to CD4 receptor, was shown to induce apoptosis of osteoblasts, including significant upregulation of pro-inflammatory cytokines and contributing to the bone loss. Other part of the viral genome, which is HIV GAG B55, a precursor protein for HIV matrix, was also found to decrease the level of osteogenesis. The relation with ART is proved also. Since people living with HIV are on ART indefinitely, continuous administration of ART has been shown to be associated with a decreased BMD and an increased risk of fracture. The earlier studies evaluated the effect of ART, proved that there was an association with use of protease inhibitor and some NRTIs and some NNRTIs. In people having ART regions that including protease inhibitor, they showed a higher incidence of osteoporosis than other regions. And this finding was further supported by several studies. In HIV-infected women, HIV infection was associated with lower BMD independent of other non-risk factors. And the protease inhibitor containing ART and particularly longer use of lopinavir were associated with lower BMD, whereas use of efavirenz has less effect. In a study performed in Korea, osteoporosis was associated with both abacavir and AZT-based HIV regime as well. يعني المسألة مش مجرد في الTDF، لا في other ARVs proved to be associated with such problem. AZT-associated osteoporosis was seen mainly after 1 year of treatment, whereas abacavir had adverse osteological effect in less than 1 year. So the recent studies addressing the BMD, bone mineral density issues in women living with HIV from sub-Saharan Africa found that women living with HIV on ART had at least 3% decrease in their bone mineral density, and it was found that it was associated with reduction in bone mineral density and maintained the level of vitamin D compared with the ART regime containing protease inhibitor. In another comparative analysis of a specific ART, it was found that Truvada plus atazanavir or darunavir or galtegravir were all associated, but the least effect was in the regime including galtegravir. Furthermore, it has been found that supplementation with vitamin D and calcium with the initiation of ART fixed dose combination may mitigate and make bone loss less than the other groups. In this chart, we see that the orange one, galtegravir containing regime, has the least effect on the bone mineral density. Some evidence suggests that women with HIV infection develop premature physiologic menopause. It means that they got menopause earlier than 50 years. And all HIV positive women are advised, especially with menopause, should be screened for bone mineral density loss. We find the effect of bone mineral density loss and causing the osteoporosis or osteopenia, and it may affect the structure of the vertebral column and the build of the women, and may cause fracture to vital areas like the lumbar vertebrae or the neck of the femur. To summarize the relation of the menopause and the bone health in HIV-infected person have 3 times greater prevalence of osteopenia and osteoporosis than the HIV-negative women. And the HIV-related factors summarized in low CD4 count pre-treatment, and it has been found that 6% loss of BMD after starting ART has been proved, especially if tenofovir is included in the regime, and the chronic inflammation, as we mentioned before, with immune activity, and the low vitamin D that is prevalent approximately in all people receiving ART, with the high levels also of bone turnover biomarkers, as we mentioned. Other general risk factors found to be in the women living with HIV is low body mass index, especially at the beginning, pre-treatment, and the poor nutrition, sedentary lifestyle, and use of tobacco. The risk of fracture in HIV augmented by co-infection with HCV, as shown in this chart. In a study from Denmark, patients co-infected with HIV and HCV have 3-fold increased fracture risk compared to the mono-infected one. The clinical picture maybe nothing is found. Osteoporosis develops slowly, and a person may not know about it at all until they experience a fracture after a minor incident such as fall down. Even a cough or sneeze in elderly people can cause a break if they are osteoporotic. The fracture will often occur in the hip, wrist, or spinal vertebrae for people who have osteoporosis. If a fracture occurs in the spinal vertebrae, it can lead to changes in the posture. Investigation will be limited mainly to the DEXA scan and FRAX score, in addition to some other special investigation. DEXA scan simply is a subjective measurement, and it can use either of 2 different scores, T-score and Z-score. What is T-score? T-score provides the standard variation from a patient's bone density compared to a young adult at peak bone density. Z-score provides the standard deviation from the patient's bone density compared to the average density of someone same gender, age, and weight. So for both scores, 0 means that this person is normal. Negative score means that the patient's bone are less dense and it has a high risk for fracture. WHA defines the osteoporosis and osteopenia, defines that normal one is the one with T-score no less than -1, and the osteopenic one is -1 to -2.5, and the osteoporotic one is less than -2.5. This is a report of a young man patient presented to me with body X, and I asked him for doing DEXA scan, and as shown with this red arrow, he got osteopenia for the vertebral part L1, and this defined by WHO as having increased risk of fracture. The other way of investigation is FRAX questionnaire. It is a questionnaire containing 12 elements regarding age, sex, weight, etc., and it gives a prediction if there is a possibility or risk of fracture. And this is the shape of the form. FRAX score calculator will lead the patient to seek medical help and treatment. So the diagnosis showing there is a risk, then treatment must be applied. There is no need for bone protective therapy such as bisphosphonate until there is a real positive score from DEXA scan or fracture score. The assessment of fracture risk would be appropriate in all patients with those measurements, and we do not need to remind you of checking the vitamin D levels and calcium as well. Baseline DEXA screening for osteoporosis is recommended in all postmenopausal women living with HIV, and other recommendations include also counseling patients about risk factor of osteopenia and osteoporosis, such as cigarette smoking, excessive alcohol, and the importance of regular exercise. We have also to remind physicians about the risk of falls in such people. So he has to get the full history about if they are taking any sedative or other polypharmacy, or they have peripheral neuropathy due to diabetes mellitus. Because of the risk of TDF, we can make a switch to tenofovir alafenamide, because tenofovir alafenamide, as you see with the red arrow, is 25 milligram compared to 300 milligram in tenofovir desoxyfumarate, desoxyl fumarate, and the TAF switching to TAF is associated with lower risk of BMD. And we may consider also replacing the whole regime by a non-tenofovir regime. So take-home message: metabolic complications that are associated with use of antiretroviral drugs differ between women and men, and women living with HIV are more likely to have decreases in bone mineral density than men, and women have an increased risk of osteopenia and osteoporosis fractures, particularly after menopause. The ART regions that contain tenofovir protease inhibitor both are associated with a significantly greater loss of bone mineral density. We shift to another important non-communicable disease associated with women living with HIV, which is the cardiovascular disease. Because effective ART has become more widespread, HIV has transitioned from progressive fatal disease to a chronic manageable disease marked by elevated risk of NCDs, including the cardiovascular disease. The relative risk of various cardiovascular disease manifestations are generally 2 times greater for people living with HIV compared to negative one. And the rates of myocardial infarction, heart failure, stroke, and other CVD manifestations, including sudden death, are significantly higher in people living with HIV. Actually, increased prevalence of non-communicable disease among people living with HIV reflect many factors, including aging and the direct consequence of HIV infection and the exposure of some ARVs. Therefore, among people living with HIV, CVD events are attributed to higher prevalence of both modifiable and non-modifiable risk factors such as age. Women living with HIV are 3 times more likely to have heart attack than women without HIV. In this chart, showing the mortality by cardiovascular disease in the duration between 1999 till 2013 in the United States, we can find that the CVD-associated mortality in general population declined during this duration, whereas the HIV-associated CVD mortality has been increased. Studies have demonstrated that chronic inflammation and immune activation are abnormal in people living with HIV, and there are higher levels of several inflammatory markers such as interleukin-6 and tumor necrosis factor alpha 1 and 2. And it has been associated with coronary atherosclerosis in HIV. Also, there are elevated levels of monocyte activation markers, which is associated also with atherosclerosis. Besides the inflammation, also there is, if there is co-infection with HCV, the inflammation will be more and more risk for CVD. Certain ARVs have been associated with elevated risk of atherosclerotic cardiovascular disease, especially protease inhibitor, as shown in that study. And that study showed that each year of cumulative protease inhibitor was associated with 10% greater risk of myocardial infarction. NLTIs, especially as the newer generation of them, having fewer metabolic side effects and presumed less toxic. And the impact of ART adverse effects on CVD risk among people living with HIV may be relatively low and may be further attenuated by use of antiplatelet agents like Plavix and statin among high-risk individuals. The decision of what ART to start and whether to switch to other regime is complicating decision and have to take in consideration the cardiovascular disease risk, the HLA-B 5701 before using abacavir, the HIV drug-resistant testing, and the adherence and the age of the lady, especially childbearing age, and other comorbidities. Also, studies of people living with HIV have found high prevalence of several metabolic diseases, which can increase the risk of CVD. So we can say that not all ARVs are risky for CVD, but some of them has got approved relation, such as abacavir use has been associated with cardiovascular disease and cardiac events in many studies. In this chart, we can see that NLTIs, whether TDFs, lamivudine, metricitabine, or non-nucleoside reverse transcriptase inhibitor like nevirapine or dovavirine, beside protease inhibitors such as boosted atazanavir, or the whole class of integrase inhibitor, have little to create as a problem of dyslipidemia, whereas nuts such as abacavir or AZT, or non-nuts such as efavirenz, or protease inhibitors such as boosted darunavir, they have intermediate effect as regards lipid metabolism, and the highest that can create dyslipidemia and considered risky for CVD complication is the lopinavir boosted with ritonavir. So prevention and treatment, we have to change the lifestyle as we do in non-HIV patient, and smoking cessation is of great importance. Also, the advice for regular physical activity is important. Present challenge associated with some new RVs such as dolutegravir, and they are causing some sort of weight gain, especially in young females, along with the increased body mass index and obesity. It is itself considered as a risk factor for diabetes, cardiovascular disease, and mortality. And this proved in many studies that weight gain following the initiation of antiretroviral therapy represent a risk factor for the cardiovascular disease. So primary prevention depends on reduction of the risk of atherosclerotic cardiovascular disease and represent a good target using the statins, but not any statin, because some statins are affected by ARVs like ritonavir. Ritonavir is a potent cytochrome inhibitor, so a statin such as simvastatin or lovastatin are extensively metabolized by SEP system and can have levels increased to more than 500% when co-administered with a SEP inhibitor like ritonavir. So drug-drug interaction should be taken in consideration when selecting a statin. Now we come to HIV and diabetes. Actually, people with HIV may be at risk for developing type 2 diabetes mellitus, and many risk factors are involved, like I will try to be more fast. Risk factors for type 2 diabetes mellitus, as in normal population, being 45 years of age, having a family history, being overweight, have HCV co-infection. And the annual incidence of diabetes mellitus among people living with HIV may reach to 5%, depending on the type of ARVs used for his treatment. Actually, approximately half of people living with HIV retained in care only. That's why we have to give more attention to keeping them retained in care to follow their HIV and their NCDs as well. Actually, cervical cancer has been spoken a lot and in a brilliant way by Dr. Chakron. Now we come to the last topic, which is depression with women living with HIV. Globally, depressive disorders are largest source of burden of mental health disease, and depression commonly co-occurs with HIV infection. Some studies report that prevalence of major depressive disorder may reach to 15%. Among people living with HIV, depression and the stigma can poorly affect health outcomes. People who are depressed are 3 times more likely to be non-adherent to ART, and the depressive symptoms are associated with attrition from care and a higher rate of mortality. Screening and treatment for depression are critical to HIV prevention and treatment. Actually, task shifting may be needed in low and middle income countries to extend the treatment by antidepressant to the physician who give primary care to the HIV patient. And despite the well-documented interaction between the antidepressant and ART, we can use the sites like Liverpool HIV drug-drug interaction to avoid such drug-drug interaction effect. We have to move them from a depressed, humiliated person to a hopeful one. In conclusion, saving the lives of people living with HIV, but then losing them due to non-communicable diseases will be a disastrous decision. Providing non-communicable disease care as a part of existing and functioning HIV care system would be logistically simple and inexpensive and represented in integrated clinic for that purpose. The package of non-communicable disease prevention, screening, and management is required for people living with HIV, especially women. Thank you very much.
Thank you, Professor Dr. Munir, for this excellent and lecture. And also thank you for Dr. Ni'matullah and Dr. Kordi for this excellent arrangement. I would like to ask Professor Munir about women with living with HIV. Is there is any advice to take a prophylaxis drug, a prophylaxis supplement for as a mineral for bone density or no? As it is taken routinely or test based?
Actually, screening is a must for ladies in menopause, and actually we have to listen to the patient, especially if the patient is complaining of bony aches. I got a lady that was complaining every time she went for the monthly treatment of bony aches, and they are just giving a pain relieving drugs, and nobody thinks that she's taking tenofovir since 2 years, and she has a possibility of having osteoporosis. And when she went to orthopedic surgeon, he gave her a joint steroid injection. So يعني زود الطين بلة. It's better to do routine screening, especially for menopause women and male above 50, and to take careful history about if the patient is complaining, and to put in mind this side effect. Especially we do not have a lot of varieties of ARVs. We have to, till now we don't have TAF in our country, and tenofovir is a drug with association, but not only tenofovir, also as we mentioned many other drugs. So we have to be careful in selecting these drugs and in monitoring the patient with required investigation.
I ask about the prophylaxis before symptoms.
Yeah,
those for high risk to be to get bone broken. Okay.
Yeah, prophylaxis represented in checking vitamin D, and also advising those people to have physical activity, because most of them they want sedentary life, and because of the stigma they have some sort of depression. And we ask them to also check from time to time, especially if they have the complaint.
Is there any data about Egyptian record for broken bone among those women living with HIV in comparison to general population?
In fact, I didn't get any Egyptian statistics. This subject should be studied, and I called for research work for that. And also, we have to live with more multidisciplinary teamwork with the also doctors, and because the care in our hospital is limited to just repeat the monthly treatment. There is no real interview with the patient. There is no one listening. As I told you, painkiller was the only thing given to the patient, kept complaining, and this patient, 39 years, a female patient with tenofovir for 2 years, she went for hip fracture, and after got hip fracture also, she didn't find any surgeon to help her, any hospital to accept her for hip replacement. So it is a disastrous situation. We have to give more attention for it, especially it is a preventable disease.
Thank you very much for this excellent presentation, and for Dr. Na'matullah and Dr. Kordi for this kind arrangement, and dear Professor Ahmed Saad, and all our brother, the colleague invited to this lecture.
Thank you, Dr. Sami. Thank you, my dear professors, chairpersons, Professor Sami, Dr. Ahmed Saad, and Professor Sahar Hassani. Our valued speakers, we had a very rich meeting. We have, I think, few questions, but we have promised our attendees to answer the questions by email. We will send an email by the question to the target speaker, and we will come back to the attendees by the results, because we are now out of time. It's now 11 p.m. Cairo time, local Cairo time. So thank you all. Thank you for all of our attendees who have. I hope you have enjoyed with us this meeting, and I hope it will be reflected on your practice and your attitude toward the women living with HIV and with the people living with HIV generally. Thank you all, and I hope to meet you soon in another meetings with the UNIT conference and with the viral hepatitis and HIV fighting group in قصر عيني. Thank you all.
الحقيقه بس قبل ما ننتقل يعني ندعو لاخونا ربنا يرحمه الدكتور محمد العتيق بالرحمه والمغفره، توفاه الله عز وجل امس. هو كان من اعمده يعني الامراض والحميات، كان مدير مستشفى حميات طنطا، وكان له طبعا كل الناس تشهد له بالجد والاجتهاد ونشر العلم والحب على الحرص على تعليم الزملاء، وكان نشهد له بالاخلاق الحميده والخلق الرفيع، فندعو له بالرحمه والمغفره. وكان من احد اعمده الجمعيه المصريه للحميات ومستشفى الحميات، مستشفيات الحميات على مستوى الجمهوريه وعلى مستوى يعني العالمي، برضو كان له دور كبير مع الزملاء المهتمين بمجال الجهاز الهضمي والامراض المعديه في العالم، وندعو له بالرحمه والمغفره.